Hello, everybody. My name is Dr. Christopher Nemeh. I'm an internal medicine resident at the Baylor College of Medicine, and today I'm going to talk to you guys about hyperkalemia and its management. That is to say, what to do when that BMP comes back with an elevated K. So let's start by defining hyperkalemia. We're going to call it a potassium level greater than 5.5 to 6.5, really depending on who you ask. But once you start to get above that level, you're definitely going to start to get concerned that you may need to start treating this patient. And so the first step in management is going to be to grab an EKG. And the reason for this is because you're going to be looking for EKG changes. The classic sort of peaking of the T waves or widening of the QRS complex may be present, but really any change from the patient's baseline is something that you may want to be concerned about and start thinking about treatment. So if there are no EKG changes, then you probably have time on your side, which means you can start evaluating for other potential causes of your hyperkalemia, whether that's pseudo-hyperkalemia, maybe you have just an elevated white cell count. You can take all these things into account because you have some time. And then if you decide to go for treatment, you can basically continue following the algorithm as if there were EKG changes, but with less concern that you may need to emergently stabilize the cardiac membrane. But what happens if you do have EKG changes? Well, then you're going to start separating your management into three camps. The first thing that you're going to want to start thinking about is stabilization of the cardiac membrane. You're going to want to think about temporization of the potassium level in the bloodstream. And finally, you're going to start wanting to think about your absolute definitive therapy, which is elimination of potassium from the patient's bloodstream. Now, starting off with stabilization, because that's going to be the first thing that you're going to want to do, your first breakpoint comes down to whether or not you have the luxury of a central line. If you have a central line, you can use 1 gram of calcium chloride. If you do not have a central line, you just have a peripheral access, you can use 3 grams of calcium gluconate. And the reason for this is that calcium chloride is more potent, but it's also a more caustic agent. So you can use less of it, but it needs to be infused through a central line. You can repeat these doses Q30 minutes as you proceed with the rest of these measures to actively treat the patient's hyperkalemia. So next we're going to talk about temporizing measures. Typically on the wards, when we're treating acute hyperkalemia, we tend to reflex to insulin and D50 and albuterol. So those are going to be the first two that I'll talk about. If you're going to use insulin, you're going to use 10 units of regular IV insulin. You're also going to give that with 100 mLs of D50 to prevent any sort of hypoglycemic complications of using insulin as therapy. You can repeat this just about every 4 hours to see an appreciable change in the patient's potassium level. Just keep in mind that it may not be as dramatic as you think it might. Furthermore, you can use albuterol. You really need to give about 10 to 20 milligrams, which is the equivalent of 4 to 8 nebulized solutions. So a lot of times what will happen is you'll just end up placing these patients on continuous duonebs and just repeating that dosage Q2 hours in order to try to lower the patient's potassium level. Keep in mind that all these temporization measures are just shifting the potassium intracellularly. So you're not actually fixing the problem, you're just kind of lowering that potassium bath that the cardiac myocytes are feeling as they're trying to work through this electrolyte derangement. And both of these therapies, while they may be effective in acutely lowering the potassium level, may not lower them beyond about 2 to 3 if you're particularly lucky. Now, there's a couple other temporization measures that I'll talk to you about if you have the luxury of an ICU setting. and that is going to be epinephrine. Again, working by beta agonism the same way albuterol does. It's just a little more potent, and it has the added benefit of simultaneously treating bradycardia that may be caused by the hyper-K. So you can kind of kill two birds with one stone here. You can also use bicarbonate. The only thing that I want to point out here is that you do not want to go to the crash cart and grab that hypertonic syringe of pre-filled bicarbonate. That is going to induce solvent drag and actually worsen your hyperkalemia. What you actually want is isotonic bicarb, and you want to infuse it like you would a resuscitation fluid. There is a caveat here. You're only going to be using this for metabolic acidosis, and that acidosis should not be lactic or keto. The reason for that is we have better options to reverse those underlying causes without necessarily needing to resort to bicarb, which, keep in mind, is only going to target your patient's pH around 7.1. Last but not least, we want to talk about our definitive therapies. That is elimination of potassium from the body. Your final breakpoint for this is going to really come down to whether or not your patient has the ability to urinate and can undergo what we call kaliuresis. If that is not an option, or you have a patient who is now post-ROSC from a code, or you have significantly elevated potassium levels and you can't necessarily safely eliminate those using medical therapies, you're going to look at dialysis as your definitive modality of therapy, and that's going to really be a mainstay. Now, if your patient can produce urine, you can try targeting kaliuresis. And that is not just diuresis, but it's diuresis with the express intent of excretion of potassium. So you can use agents like Lasix. You can augment Lasix with a thiazide. And again, if you have that ICU luxury, you can even add on a third agent, acetazolamide. Just keep in mind that this will really prime the pump, and this patient will start to dump potassium to the point where you may actually end up chasing this potassium and giving it back in order to sort of undo what you've done clinically. You can also use an agent like fludrocortisone. Again, just sort of stimulating that mineralocorticoid effect of excretion of potassium. And remember that anytime you're going to utilize diuresis as a therapy, you're going to want to give back fluid. And your first thought might be, well, I'll give NS because normal saline doesn't have any potassium in it. That's actually a contraindication in hyperkalemia. The hyperchloremic metabolic acidosis will, due to the strong anion difference, will actually worsen your hyperkalemia, and that has been demonstrated in head-to-head studies. You want to use something like LR. The fixed concentration of potassium in LR will simply drive the potassium level toward the number 4, and you really have nothing to worry about. It is a safe fluid and is actually the recommended fluid of choice. Finally, you can try to have the patient excrete the potassium via the GI tract. If you're going to do that, historically we've used things like K-oxalate, newer agents like patirimer. However, we have no evidence to suggest that acutely these medications are able to lower the potassium. They're more so for long-term agents, and there's a lot of baggage that comes with K-oxalate. We don't use sorbitol anymore, so the risk for bowel necrosis is less, but it's still there, and the acute benefit of K-oxalate was from it when it was paired with sorbitol. That promotion of a bowel movement was what was acutely lowering the potassium in those patients. And so we have safer agents that we can use to promote bowel movements in our patients for GI excretion of potassium. And according to the American Association of Nephrology, we really shouldn't be using K-oxalate circa 2012. So use another agent. We like to use lactulose. Try to promote a bowel movement, see if you can lower the potassium that way. And if all else fails, you can always fall back on hemodialysis in your intensive care unit. So in a nutshell, the first thing you're going to want to do when your potassium is elevated is check that EKG. Make sure there's nothing acutely changing that you need to worry about. If you see anything there, start thinking stabilization with calcium. temporization with insulin beta agonism, and potentially epinephrine isotonic bicarb if you have the right setting. And ultimately, elimination. If you can promote calourisis, absolutely do so. Remember to replace that fluid with LR. Give the patient a dose of lactulose to see if you can promote a bowel movement, and don't be afraid to place that Quentin and go for hemodialysis. And that's hyperkalemia. Thank you all.